Good afternoon, everyone. It is my pleasure to welcome you all to this hybrid webinar titled International Perspectives on Data to Action Insights from the Child Health and Mortality Prevention Surveillance Program. I'm Dr. Maria Tariq. I work with Department of Pediatrics in JAM study, and I'll be your moderator for today's session. I would like to begin this session by recitation of the Holy Quran, and for that, I'll call Mr. Hamad.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد صدق الله العظيم.
Jazakallah. We are grateful to the Department of Pediatrics and Child Health at Khan University for organizing this insightful event where we will hear from leading experts on the critical findings from the CHAMPS program and how they translate data into actionable strategies for reducing under 5 mortality in Pakistan and globally. Our session today is going to be filled with a wealth of knowledge and diverse perspectives as we look at the ways CHAMPS contributes to public health policy development and preventive strategies. To kick off our session, now it's my honor to introduce the site PI and Director of CHAMPS, Dr. Momin Kazi, an Assistant Professor at Khan University. Dr. Kazi has been leading significant efforts in infectious disease and global health research, and today he will walk us through the CHAMPS study in Pakistan. The stage is yours, Dr. Kazi.
Bismillahirrahmanirrahim. So it's a great honor. Thank you so much. So I was just talking to Rosemarie that it's kind of a dream come true that we are in our second year and we are already presenting our data. So with that, give me the honor to I would first like to welcome our guests from US, the CHAMPS team. I'm also would like to welcome our government partner. I see Dr. Nasser is here. Thank you, sir. And I'm hoping that I'm hoping there we'll see more people from our Pakistan Pediatric Association. I see Dr. Ali and Dr. Naveed here. Thank you, sir, because this for us is very important that we disseminate our data, especially related to the child mortality, and clinicians and pediatricians play a very important role. I would also like to welcome my team, our AQU colleagues and leadership. And since this is a webinar, we are hoping that we'll have a big audience through the webinar online. So I would like to also welcome our colleagues at UT Southwestern. We see some of our colleagues are here. I hope all are, so would like to especially welcome our colleague from UT Southwestern, at Yale, the CHAMPS program office, and our friends and colleagues at CHAMPS site. So this is basically, so I'm going to walk you through the initial, the methodology part and some of the mortality work which we also did. So me and Dr. Saad bin Umar, who's the inaugural dean at the School of Public Health at UT Southwestern, we are the PIs of CHAMPS study, and so we'll share some of our other work as well. So as you know, Aga Khan founded in 1983. It's one of the first private medical college. And beyond world-class teaching, research, and health delivery, and Department of Pediatrics currently have 79 active grants. And we work with major donor agencies. So before I talk about CHAMPS, I'm going to take few minutes on, and you guys can tell me about the, you can keep the timekeeping, all right. So I'm going to walk you through our health demographic sites, basically, demographically known as SDSS or Vital Registry. There are 6 sites where Department of Pediatric work. It is a maternal and child surveillance in which we follow all the pregnant or the married women and their children under 5 years of age. The total population is around more than 500,000. For our mortality study, we follow 3 sites, which is Ali Akbar Shah Behans Colony and Ibrahim Hedri Extension, with a population of around 261,000, and we follow around 38,000 children. Not here. We also, so since we follow them every 3 months, so we have the denominator of exact mortality of children under 5-year, neonate mortality, and other, and pregnant woman mortality, because we are following the population every 3 months, and that's our denominator data. Again, so I think when we started our work around 7 years back, the main question was, okay, what can you really capture mortality data or samples of from children after their death because of some specific religious cultures as part of the community. So Islamic burial practices prefer a quick time between death and burial. Reason could be unrest of spirit prior to burial. In some community, they don't allow us to touch the body, and burial garment should be clean, so even after the process, there should be no seepage. And so procedures need to be deemed permissible, fatwas by religious leaders of faith in the community. And so we followed a scientific strategy, which I will talk about in a minute. And so in these last 7 to 8 years, we are able to capture around 1,000 nasopharyngeal swab, around 100 MIT samples, and the major buy-in is the religious acceptance through fatwas, study staff residing in the community, study staff, and then our response time is that we are able to reach them in 20 minutes. So we start all our studies irrespective of the same community with formative phase and community engagement. As I talked about, we have around 15 fatwas, majority from the religious scholars of different sects, as well as Christian and Hindu temple. And since this fatwa is cannot be named after an organization, it's kind of, it's in my name, so it's Dr Momin Kazi, and so my other specialty is people call me a fatwa doctor as well, but it works well. So I think the major, what we learned through our journey is the first question they ask is that the process of collecting samples after mortality, is it allowed in our religion? And any religion, and so fatwas and the religious letters really worked. Then the meeting with the stakeholders, the key stakeholders who are part of the whole ritual process. So liaison with them is very important, and then we communicate with them through different meetings and religious gathering, including the Friday prayers. So our typical process is that we once we get the alert, we go to the household, and so our surveillance is based primarily at collecting the sample outside or inside their home, depending on the sample. And once the sample is collected, then it is transported to to our central lab at AQU as soon as possible. So this is the initial van, which was designed by the team, primarily Saima and Nazia, which now is the 4th version of the van we right now have for our CHAMP study. The other component which we are very proud of is grief support. So all the families of the deceased child, irrespective of whether they consent or not, we provide them grief support. We have a trained team and a trained psychologist. And in addition to that, we also provide grief support to our staff to make sure that, a mortality, with the pressure of a mortality study, the staff grief support and the mental health is also covered. So up till now, we have done 4 major surveillance study, and CHAMP is our current work. So we started our journey with collecting nasal swabs of children under 6 months of age. And in that study, we collected nasal swabs, and we of around 600 kids, and we who unfortunately passed away within our catchment area. And we saw a 3.7 burden of RSV in those children. And this data helped, especially the international organization like Gavi and WHO, for the recommendation of RSV maternal vaccine. In addition, we also saw around 24 MITS samples, lung MIT sample of these children, and of a sub-sample, and able to see some of the cases which, if the MIT sampling was not done, we would not be able to see. Moving forward, we also did a burial study in which, this is during COVID, and we were interested in looking at the graveyard data. And so we kind of covered 97 graveyards, and out of those, we captured around more than 200,000 records. And we saw during 2016 to 2022, there were 3 peaks, 1, 2, and 3, in which we were able, which clearly showed that these were peaks during the COVID time. And when we covered, compared those with the government data, they were quite comparable, and the difference was maybe 2-fold or maximum 3. We were also able to make a e-portal and a dashboard, and we are in the process of sharing that with the Government of Sin and Commissioner Office. And this is work in progress, which is helping us looking at different mortality trend through non-invasive mechanism. The second component of the study was we took a subsample of 350 in a catchment area of children and adults who unfortunately passed away or within the catchment area. This is post-COVID, and then we saw a 6% burden of COVID in those cases, with Klebsiella pneumonia, Staph aureus, Streptococcus pneumonia, Haemophilus influenza as the main contributor to these deaths. We also did verbal autopsy of a subsample of 1,500 adults and children, and saw that acute cardiac disease, diarrheal disease, perinatal asphyxia, and stroke was the major cause of mortality among these cases. So shifting to CHAMPS now. So this is a multi-site study. Pakistan is the 9th site. So me and Dr. Saad bin Umar are the co-PI, and very proud to have a very dynamic team with Professor Farah, Professor Asbeg, Dr. Zara, Dr. Imran, Dr. Zishan as the co-investigators, and we have Dr. Fawzia and Professor Yildirim from Yale as the co-investigators. This is my core team. I think this is the main team, I would say, who's working and doing all the hard work. So we have this is a 24/7 surveillance. So the team in Pakistan and UT Southwestern actually are working 24/7. When one team is up, the other has to be up again. And when the other team is up, then the initial team has to be up again. So I don't know when do they sleep, but it's a very hardworking team. And so the process is that, the CHAMPS consist of basically 4 components. It has a social behavior component. It has a mortality surveillance through which samples are collected, and then sample collection through minimum invasive tissue sampling, and then a decode process which is cause of death. And this process will be further details would be shared by Dr. Shabina Ariff. So in principle, so we collect four tissue samples, which is lung, heart, liver, spleen, and brain, lung, heart, liver, spleen, abdomen, and then we collect blood, nasal swabs, CSF, and anal swab. So again, so these samples are collected outside the participant's home or at one of the hospital in a van which we have designed. Now, this is the most common question I've been asked: how do you collect the sample? So that is something which we learned the hard way, but I think we followed some scientific principles, both of behavior science and clinical science. So we have a very, again, we talked about the formative phase, that we have the fatwas, and then we meet the specific stakeholders, and then through that process we have community engagement. We meet the community on continuous basis. We meet around 3,000 to 4,000 people in a week. There are specific stakeholders or categories we meet, which is in the pathway of the barrier process. So and the important stakeholders, so religious leaders for religious buy-in, and for community buy-in, funeral workers, healthcare providers, community workers, elders, and community leaders. And so the two things which we expect from them and is very important is basically, so through them we identify who are our key informants, and those are the people who inform us about the death as soon as the death occur, and unfortunate death occur, and also join our team to collect the sample. The sessions are, it could be individual sessions, group sessions, town halls. We do iftar town halls and religious town halls. So different activities at different community level. Then it requires a rigorous training. I've already talked about the key informants, and then we monitor the process and also look at that what are the Q&As. Are there any new questions from the community? And those questions help us build our advocacy process, help build our methodology process, so that we can improve our methodology in reaching the participant as soon as possible and talking to them and getting the sample and the consent. And also this is part of the routine well-being and joins with the grief support as well. So again, I think I've talked about it, but what you have to remember, this is on an average at 15 to 20 minutes process. So we get in WhatsApp, the team communicate within themselves, we reach the household, we talk to the family, and then once we collect the sample process requires around half an hour to 45 minutes, and then it transported to the main AKU or to our IDRL at here in the university building. So we are very proud in the sense we are since 7 years, and we are one of the site which only collects the sample in a van. And so itself, making the van itself is a whole journey itself. We have even published paper and multiple IDIs and FGDs to understand how the van look like from inside, for outside, what you should call the van. It should be a MITS van, it's not an ambulance. And so this is something which we learned or took input from the community, and that's why it's the size of the van, so it can fit in those lanes, and then can be parked as close as possible to the household with the child, unfortunately, where a deceased child is. So after collecting the MITS van, so we go to the on-site facility, or again, depending on time of the day, directly to our lab in the university setup, and the samples are transported to IDRL lab. So and again, following all the logistic, we even have liquid nitrogen, because these are precious samples. And the other thing which is very important is that because most of the community lives within the catchment area, including key physicians and healthcare providers, we are able to collect and do the process so quickly. These are some of our major forms, and so the form we have a stringent QC team. So both at the household, at the field level, and at our central level, and so it's very important that all the QC process is done, so that we can then upload it for the decode process. I'll quickly go through this data. Dr. Shabina is going to talk about in detail, but up till now, this is our second year. Up till now, we have collected around 386 MITS and non-MITS samples. MITS are minimum invasive tissue samples, so we have collected up till now 72 minimum invasive tissue samples, and those who did not consent for MITS, we have collected their verbal autopsy and their child and maternal history from the hospital. And so we have just finished around 55 decode cases. So once once we have the complete data, it goes through a panel, and they decode and come up with the final diagnoses, and Dr. Shabina is going to cover that. The other thing which we are also following very closely is that how many are stillbirths, and how many are children which are post-neonatal, neonates, and 1 to 5 years of age, and our home and hospital stratification. So for year 1, which was which was June 2023 to July 2023 to June 2024, we have collected around 55 samples, and up till now, from July till October, we have collected 27 samples, and so we have around total of 72 samples with around 24 stillbirths and 48 under 5 years of age. For overall MITS and non-MITS, this is the ratio which proportion which we are looking at. So this is around 35% home deaths and 65% hospital death, and that's the central part of, or I would say the focal part of the surveillance I've talked about. So, the way we have designed included collected all samples in the van, so that we are able to collect both the mortalities at home and in the hospital. This is our decode panel. I'm grateful to everyone. It's been a very, very hard work, and I'll let this picture further. Dr. Shabina can define this picture, but I can talk about Dr. Shabina, Dr. Asim, Dr. Farah Qamar, Fareen Yusuf, Dr. Fareen Yusuf, Dr. Zishanuddin, and Ms. Anita, and Mr. Furqan, very close to Dr. Furqan, and then Dr. Shyam, myself, Fatma, Dr. Sana, and Dr. Maria are part of this panel. So I'll finish off with a couple of slides, and so I think the main, what I've heard in my around 19 to 20 years of public health experience, that the one important component of this study is data for action. And it's not only that you collect the data, but how do you utilize this data or have different interventions and liaison with the government during the process itself. So we have Professor Halima, Professor Nasser, Dr. Syed Fardad as our collaborators of this study, as well as Dr. Saqib Sheikh. And we not only met the Minister of Health, and we met the director of NIH Islamabad as well. And so we are hoping not only to collaborate with them, but continuous collaboration and do specific projects with them. So again, I'm grateful to the team. This is not, so I'm just a front person. I think it's been a wonderful journey up till now. It's very hard work. I'm especially grateful to the community we work with, to the participants, to the deceased family, to our field staff, and all our collaborators, our DCODE team, and our study team. Thank you so much.
Thank you, Dr. Kazi, for providing us with a comprehensive overview of the CHAMP study in Pakistan. The importance of strong collaborations and partnerships in achieving public health goals cannot be overstated. Next, we are privileged to have with us Dr. Portia Mutevedzi, Senior Director at the Emory Global Health Institute. Dr. Mutevedzi will dive deeper into the data insights from CHAMPs and the DCODE process used to determine causes of under 5 mortality. Her work is instrumental in ensuring that data can be translated into practical health interventions. Over to you, Dr. Mutevedzi. Okay. Sorry for the inconvenience. I'm pleased to introduce Ms. Rosemarie Henson, Chief of Staff for the U.S. CHAMP Secretariat, who brings an exceptional background in maternal and child health. She will share how CHAMPS contributes to shaping global health policies and preventative strategies in a variety of contexts. Ms. Rosie, we look forward to hearing your thoughts.
Thank you. The slide pointer and the slide change.
Thank you very much. Can you all hear me? Sometimes I have a light voice. I'm not sure why that is. But anyways, I want to, first of all, I just want to start by saying I'm not sure that Dr. Momin is a front man. And I've been here for a week visiting the site, and he has done such an outstanding job of providing the leadership and hosting us and really being very transparent about the work, where the problems are, where the successes are, what the timelines look like. And so Portia and I are just very, very pleased. And I also want to thank the team who've made this possible. You all have been so gracious and so helpful. So Dr. Momin, thank you for everything. Okay, so my job today, you are going to hear from Portia. Right. Portia could have gone first, but it doesn't matter. But Portia is the scientist here. I'm more the program person, the strategy person. I'm the one, along with the PI, Dr. Whitney, who works with the Gates Foundation to make sure we continue to have this investment. It's the network and the program office staff, particularly people like Portia, who make this happen day to day. So I'm gonna talk about CHAMPS and its framework and our strategy, and then Portia's gonna talk with you about the results of CHAMPS. And so the focus here is to build knowledge, and our ultimate goal is, for everybody in this room, is to save children's lives. And we're gonna, talk about the overview, the results, the new directions. So let me start with the first slide here. I think that everybody would agree in this room that too many children under the age of 5 die from preventable causes of death. And CHAMPS was established to provide accurate and definitive data for childhood mortality. That's really the purpose of CHAMPS, okay? That's what the vision is. And what we've seen is that the largest burden of child mortality happens in places with little or to no information about the causes of death. And so with our work with the Gates Foundation, we've really been focused on South Asia and in Africa. And so I think that many of you as scientists in the room are most familiar with the models that have been widely used to understand the causes of death. And it's based on, it's not that we don't have any information, the information is imperfect. So we know that many deaths occur out of the hospital or shortly after a short stay. And we know that diagnostic tests are not widely available. We know that verbal autopsy is used, but isn't specific enough. And we think about the cause of death as being a single cause. And we can tell you from CHAMPS, and Portia's going to tell you this, that that isn't the case. Okay, so our overall objectives, and I want to tell you, I joined CHAMPS in 2019. So CHAMPS started in 2015. That's when the Emory University, the PI then was Dr. Jeff Copeland, who's very well known, previous CDC director. So he was the original PI, and this was presented as the overarching objectives, to track definitive causes of child mortality in sites throughout Africa and South Asia, with a real focus on using minimally invasive tissue sampling to produce and disseminate high-quality data to help inform policy and public health action, which Portia, again, is going to tell you more about, and then to enable sites to take the investments that we've made in the infrastructure to prevent mortality, to really focus on data to action. So this is where we are at. These are the sites within Africa and in South Asia. You can see here we have 9 sites. As Momin was saying, Pakistan is our 9th site. So Pakistan is very early in its development as a CHAMPS site. So Pakistan is doing well, doing very well. And you can see here we have 9 sites, but it's important to recognize, and we in the program office need to do a better job of this, we have 20 catchment areas that are currently performing MITs. And we're ready to launch in Bauchi, Nigeria. So gives you a sense of where the surveillance activities are. We're restricted to work in South Asia and in Africa, and I can answer questions about why that is the case, but that is our directive from the Gates Foundation. And this is a really important slide because one of the things that you wanted us to talk about is partnership. And so when we set up CHAMPS, you can see here, Bill and the Melinda Gates Foundation is primary funder. You can see that we have in the US a CHAMPS program office. You can see that Emory University right now is our administrative home. IOMFI is the group that works very closely with the public health institutes around the world. The Centers for Disease Control, we work very closely with their laboratory, a couple key laboratories. And then the Task Force for Global Health is critical in that it is where all our informatics happen, okay? And then you can see the sites have done a great job in terms of pulling on partners, pulling together partners to implement CHAMPS. We also do have a global partners board with representation from various leaders and experts around the world. One of the things that I want to make clear, and I'm sure the Pakistan team gets this right now, this is a difficult project, okay? My background, I worked for the Centers for Disease Control for 19 years. I worked everywhere in the agency. I used to, in various leadership roles, we invested in a lot of work in the States and in globally. I have never seen anything so difficult in my life, okay? So it is amazing that we are able to do this work. And quite honestly, we think about CHAMPS as a global good. And in the 9 years that we've been in the field, we're in our 10th year, we've made exceptional contributions to the world's understanding of child mortality. And the network functions really well. But let me tell you about what it takes to launch this type of effort. So first of all, Momin talked about this, is working with families, working with communities is just critical. We can't do this work without building community trust and partnerships. We need to have a good understanding of local cultural practices. The staff across the network have to learn how to work with grieving families in this is very sensitive time where they've lost a child. And in many regions, and we understand this in the program office, that we have to adapt and to accommodate the cultural practices. The lab and clinical capacity is a big, big component of what we do in CHAMPS. And what we've been able to do in many of our sites is to build laboratory infrastructure. And again, Portia will talk more about that. There were few trained pathologists. There was not a lot of practice in terms of postmortem examination. You all know this, working in the clinical sector, medical records are often incomplete and missing, and not a lot of resources for postmortem diagnostics. In addition, we need a lot of analytic capacity, and so we are building that capacity not only at the site level, but at the program office level. So it's critical that these pieces are in place. And most important, are partnerships with the ministries of health or the hospital systems across the network. We are also think about CHAMPS, and this is going to be is a big part of our work now and as we move into the future, is that the data empowers people and organizations to act. And this is a very nice slide that really speaks to how we're working with families, how we're working with communities, our work with health facilities and doing mortality reviews with clinicians. It is important to note that this is a very important academic collaboration and that the data, the CHAMPS data, is openly available to the academic community and to partners. So you need to know, that's an agreement we have to come to with the Gates Foundation. We can't collect this data, keep it in a safe, and not share it with anybody. So it's always available on our website. Coordination with public health is critical. Portia will talk about the work that we do with ministries of health and public health institutes. We work closely with WHO. We've been working closely with PEPFAR on pediatric AIDS. We've been working closely with various modeling groups around the findings of CHAMPS. So right now, phase 1 began in 2015, and so we're right now in phase 2. Phase 2, we did add a couple new sites. We started to do much more work around data to action. Really, phase 1 was around proof of concept. Could we actually do this work? I mean, there are many that believe that this wasn't work that we're going to be able to do. And then we're moving into phase 3. And that's part of why we're here this week, is that starting in July of 2025, we're going to start a new project period. So what I really love about this work is that the Gates Foundation had a long-term vision for CHAMPS. And the concept was that we'd fund CHAMPS for 20 years. Highly unusual, in my experience, to have that type of investment for the kind of work that we're doing. So the objectives have changed a little bit, but they're similar. Going to focus on identifying and tracking definitive causes of stillbirth and child mortality in Africa and South Asia using MITS and cutting-edge diagnostics. We're very, very focused on the timely dissemination and communication of CHAMPS findings for health practice, planning, and policy. The objective 3 is new, which is to use the CHAMPS network in collaboration with key partners like yourself to implement and to investigate and test data-driven interventions to reduce mortality, to reduce maternal and child mortality. And then objective 4, we have a directive to make this program more efficient. This is a really expensive program, and to invest more in network excellence, to accelerate progress and program impact. So I'm going to share with you a little bit. We just finished the grant. It's at the Gates Foundation. I'm expecting agreement from them by November for the next 5 years. So we're very fortunate to be working with Pakistan and the other sites, but we will be continuing. So just to keep that all in mind, this isn't going to end in the next couple years. So what's new? So Portia will be working on increasing our support for our work with ministries of health and public health institutes and working with other key partners to ensure that CHAMPS data is disseminated and used. The important operative word is that CHAMPS data is being used. We'll be expanding our data to action activities. We also are going to start doing more work around evaluating the causes of maternal death or deaths. We need to do some improvement in terms of our data collection efforts, our diagnostic systems. Most likely we'll be doing work to incorporate AI methods in our work to streamline our decode process. We're thinking about applying AI to our verbal autopsy process. We're also going to spend a fair amount of resource into doing a better job of using the CHAMPS data and using this expanded data set. And so we're given some thought in terms of building a larger analytic team that will be both in the program office and in the field. We have a wonderful platform. Network is a wonderful platform. They work well together, and so the CHAMPS program is a program that Gates looks to in terms of being able to evaluate interventions such as vaccines. And we're going to do more work in terms of a detailed examination of how deaths we enroll represent all the deaths in our communities, countries, and regions. And then finally, we're going to have a finer focus, an enhanced focus on network excellence. We're looking at a possible new site in Central Africa. We think that there's an opportunity here to create a CHAMPS-light model so that the methodologies that we have can be used by other ministries of health, other countries around the world. So that is going to be an area of focus. The network is going to have priority areas where we have network working groups. And then in phase 4, we've had a long discussion with the Gates Foundation about this. The program office is going to work to move. The U.S. office is going to work on transforming and transitioning the program office to Africa or South Asia. And then we, as a Western institution, will fade into the background. We'll be there for technical assistance and support, but the operation will be moved overseas. And that's the vision. That's the vision that we're working with. In addition, on the CHAMPS platform, we're well positioned to add on research or data to action projects. And then finally, we have moved into a stage where we're looking for co-funding to help support both the core operations and added projects to the CHAMPS platform. So those are the new things that are going to happen in CHAMPS in phase 3. So I'm going to turn it over to Portia. She's going to introduce, you want to introduce Portia again? You can introduce Portia again. And she's going to talk about our results and our findings and the good work we're doing in data to action across the network. And then I gather we'll be open for questions. So thank you very much. Yeah. Yeah.
Thank you, Ms. Rosie, for highlighting CHAMP's global impact and the importance of preventive strategies in maternal and child health. Next, we are privileged to have with us Dr. Portia Mutevedzi, Senior Director at the Emory Global Health Institute. Dr. Mutevedzi will dive deeper into the data insights from CHAMPS and the decode process used to determine causes of under 5 mortality. Her work is instrumental in ensuring that data can be translated into practical health interventions. Over to you, Dr. Mutevedzi.
Good afternoon to you all, and thank you for the opportunity to come and present the CHAMPS work that we're doing globally, especially with a focus on how this data is really critical in reducing maternal and child health. So I'll briefly talk about how CHAMPS works, how it's set up, and then I will transition into the results, and then finally I'll talk about how we're using these findings to improve, firstly, the communities in which we work in, and then for a more global impact. So our CHAMPS data is a mortality surveillance, but it's not your typical surveillance where we are counting numbers. It's a surveillance where we work with communities to get buy-in for all the CHAMPS processes and procedures, and this is mainly done by our community engagement team. Underlying the community engagement are community advisory boards, and this includes religious leaders, traditional leaders, community leaders, as well as community influencers. We try and get to hear the subtle voices that you wouldn't normally hear if it was just a mainstream surveillance. We tend to want to understand communities, how communities function, and then work in synergy with cultural systems and practices for us to be able to address maternal and child health issues. So the community engagement team prepares us for our work. The surveillance team goes in and collects the data, and within the surveillance, we have a population-based demographic surveillance, we have a pregnancy surveillance, and the pregnancy surveillance was really in response to what we were finding. So we didn't start with the pregnancy surveillance, we added it in based on what CHAMPS was finding. We enroll the case, and then there's a panel that sits that determines the cause of death. So the way that CHAMPS functions, as I alluded to earlier, is that we are not just a surveillance. Our starting point is research and surveillance. We link this into implementation science, and we think that Pakistan is really at that critical point where there's data coming in, and we want to engage all key partners and stakeholders so that we can move into implementation science. What are we learning in CHAMPS that can be used for programming, scale up, influencing policy, and then create really a global data set that can be used to address health issues, especially in resource-limited settings. I'll just briefly touch on the methodology since Dr. Momin has already gone through it in detail, but suffice to say, we take the MITS findings, We combine it with clinical data, verbal autopsy, as well as social and behavioral sciences data to come up with a cause of death. So by so doing, we're actually able to get clinical causes of death, health system causes of death, and also the social and behavioral issues that come into causes of death. Our coding is basically determined by the WHO ICD-10 or ICD-10 11 standards. So we try and make it standardized so that it can be extrapolated to other areas where CHAMS is not necessarily happening. Just to give you an idea of where we are with enrollment, Dr. Momin has already alluded that they have about 70 MITS cases with 50 that have gone through the decode process and they know the cause of death. Across the network, we have just over 7,000 deaths that have been decoded. And you can see that the difference, the distribution is about a third in each. We have 37% stillbirths. We have 12% infants. We have 7% late neonates, 17% early neonates, and then death within 24 hours, we have about 15%. We try and go in depth in these categories because the interventions that are required really are related to the age at which the child passes on. So that's why we try and break it down, determine causes of death for specific age groups so that we can have targeted interventions. So I'll start with a case example that just shows the usefulness of CHAMS data in teasing out and getting granular information on causes of death. We had a female that gave stillbirth, 35 weeks gestational age, and the weight was 3.8 kgs. So we really couldn't understand what had happened to this baby in the uterus because the age, the weight was good. The gestational age was also good for her to give a viable baby. This was a teen pregnancy, and the mother had 4 antenatal visits. So WHO recommends that the minimum number of ANC visits should be 4, so she fell correctly into the recommended group. Post-mortem HIV, malaria, and TB testing was negative, so we really wondered what had happened to this baby. In the causes of death, pre-mortem, they had felt that this was due to obstructed labor. We tested the child and found that she was positive for Treponema pallidum. Both the mother and the surviving twin were then treated of syphilis. So this is a classic example that shows misdiagnosis during antenatal care, during delivery, that otherwise could not have picked up if this child had not enrolled in CHAMS. And most likely the twin would have also demised if they hadn't received treatment. Now going on to look at what are really the causes of stillbirth. Driven by this stillbirth case that we see, we really go in depth to say what's really causing these stillbirths that we're seeing. The majority is perinatal asphyxia and hypoxia. And in our low resource settings, we find that this is a bigger problem even above preterm births because we see birth asphyxia even for our healthy babies, the ones that we think are really viable and should be surviving. We also have congenital birth defects. I think in the Pakistan data, in previous studies, this has also come up, and we see a lot of it in some of our sites. Interestingly, though, 71% of our stillbirths are due to maternal conditions. So if we address maternal conditions, we reduce stillbirths, we also address maternal deaths. And this has driven the new objective that Rosie spoke to, that is really looking at investigating maternal deaths and doing meets on maternal deaths so that we get a deeper understanding of what is happening. Timing of stillbirths, as this helps in terms of prevention of stillbirths, we find that 46% are antepartum before labor. There are a lot of infections during this period that we've picked up. Intrapartum, we have 35%, and these are the deaths that are really occurring due to delivery complications. So if we had a way of detecting high-risk deliveries, transferring them on time, we would likely save a lot of these stillbirths. We have about 19% that still remain unknown. We've looked at the maternal records, we've looked at the stillbirths, the meats, but we are not really certain what caused the stillbirth. Most interestingly is that a high proportion of our stillbirths are linked to pregnancy, and these are preventable. So this is really exciting in the sense that there is something we can do about these deaths. There's complications of placenta and cord membranes, 70% of those are preventable. Maternal, medical, and surgical conditions, 87% of those are preventable. And about 95% of complications during labor and delivery are really preventable. And then if we go to our neonatal underlying causes of death, we see neonatal preterm birth complications now coming into play. There's also still a lot of perinatal asphyxia and hypoxia. If we address the hypoxia issue, we address stillbirths, we also address major causes of neonatal deaths. 58% of our neonates have got more than one cause of death. So this speaks to the need for multiple interventions targeting several things. If we look at the global burden of disease, the way that is presented gives an impression that there is one cause of death per neonate, but through CHAMPS, we're learning that it's really a complicated combination of things that lead to these deaths. A classic example is a preterm baby who's put in an neonatal ICU. They get a nosocomial infection. Within a week, they've passed on. If we look at stillbirth and neonatal sepsis, we do see Klebsiella pneumoniae coming up as one of the pathogens that is implicated as a cause of death. And these are usually drug resistant. So this really causes concern in terms of what are we using to treat these neonates and how we're dealing with this infection. If we look at when the infection occurs, so if you look at the bottom there, the green color represents our stillbirths, showing that these infections are acquired before, during birth. So we see a lot of E. coli coming in, we see strep. And then if we look at what happens after birth, from the environment, we see a lot of Klebsiella pneumonia and Acinetobacter. And this is really an indication of infections that happen in our hospital, in our NICUs. We move on to infant and child causes of death. We really see a transition in causes of death. We see malnutrition coming in heavily, and malnutrition is usually in combination with other infections. We are still in the process of teasing out the causality pathway. Is it the malnutrition that leads to the infection, or the infection is chronic and then it leads to malnutrition? However, we have already started malnutrition programs to address this main cause of death. We see malaria cases coming up. What was really surprising to us, and especially because we started in the African sites, was the fact that 8% was due to HIV. Our assumption was that we have mature HIV detection and treatment programs in our countries, so we didn't expect to be seeing such a huge proportion of child deaths being to HIV. And then we have lower respiratory infections also coming through. 70% of our child deaths have got more than one cause, and 40% have got more than 3 causes. So it's really, we really need to put our heads together in the country, at the catchment, to see how do we really address these issues, especially when it's multiple causes of death causing one death. And 90% of those are of an infectious cause. Taking a deep dive into pneumonia. Pneumonia is something that we've found to be very common across our sites, and it's also evolving in CHAMPS that we have a number of pneumonia cases. So we really looked in depth to see what is happening with pneumonia. We have nearly 50% of our post-neonatal deaths being due to pneumonia. And if we look at what are the common pathogens, we have Kleb pneumo coming through. Again, we see strep pneumo, and then we see CMV also coming in as major pathogens causing pneumonia. Pneumonia is common in deaths with malnutrition, HIV, and sepsis, including congenital birth defects as well. And about half of our pneumonia cases were not even treated with oxygen. So we asked what was the reason for this, because this is standard treatment. Was it late arrival? Is it misdiagnosis? Is it issue of oxygen supply? And this really drives to some of the data to action activities that we would like to do with key partners. Understanding if there isn't access to oxygen, how do we collaborate to make that available? If it's misdiagnosis, how do we work with our healthcare workers? How do we contribute to lab diagnostics to make sure that we get an accurate diagnosis? My last case study is on HIV, looking at missed opportunities for HIV. So we have a baby that came in, a 6-month baby that had demised. The baby had not been gaining weight. The family had been accessing traditional medicine, and this is very common across a lot of our sites. So the baby had been taken to a traditional healer, and they had also gone to several clinics as well, but they could not find out what was wrong with the baby. The baby then developed a fever, had trouble breathing, and died at home 6 days later. The CHAMPS testing found that the baby was HIV positive. There was severe malnutrition and wasting, and we detected both bacterial and viral pneumonia. The mother did not know that she was HIV positive. She had tested the first antenatal test. She was negative, so she assumed that she was negative throughout. The health facility also assumed, so that did not help because they did not follow up with another HIV test. We then shared the results with the family. We tested the mother, and she was treated for HIV. So this classic CHAMPS case brings out a lot of key issues. Misdiagnosis in the baby. This baby was already 6 months old, and they should have received a PCR test at 6 weeks. There was delays in care seeking, and these delays are really intricate and complicated in the sense that we see it as delayed care seeking, but the family was seeking traditional healers. So how do we integrate mainstream health to non-mainstream health so that we're able to pick up some of these issues? Misprevention opportunity. The mother was coming for antenatal visits. She was in the health system, but she was not tested. So this is a misprevention opportunity. And then the impact is that it gave us an opportunity for us to talk to the family, get the mother tested, get the father tested, and put them onto treatment. So this is another classic example of the data to action work that we would like to implement and work together with the team in Pakistan so that our surveillance is not just a surveillance, but it really speaks to issues that are happening. And in our research, we found one of these articles that was showing that HIV is possibly on the rise in Pakistan and something needs to be done about that. And the CHAMPS platform really becomes a critical platform that is well-resourced to be able to identify some of these deaths. So what we found, which is enlightening, so the CHAMPS program is really, it's a difficult program, and the communities see it as a doom program because we're talking about mortality. This mortality is not easy. It's not a 90-year-old who had lived their life and, you know, the family is celebrating a life well lived. These are really under 5 deaths that are critical, and it's a sad moment. But what really brings hope is that 8 in 10 of these deaths are preventable. So we went back to the Gates Foundation. The first phase of CHAMPS did not include detailed data to action intervention. So we went back to our funders and we said, we really should be doing something about these deaths. They agreed with us, and going into the next phase, we're now going to look at which priority areas should we work on, not at the network level, but at the country level, because our countries are different, our health systems are different, and our priorities are different. So we really want to look at how can we capitalize on these statistics that we're seeing. How can we save 75% of stillbirths, and how can we save 83% of our neonates as well as child deaths? In terms of the strategies that we've seen, and these strategies are mainly driven by our decode panelists. So when the decode panelists sit, they go beyond just determining the cause of death, and we're really appreciative of this because this is done by local experts, local doctors that really understand the health system. So they go in depth and say, was this death preventable or not? And what interventions would have led to prevention of this? So we see improved antenatal and perinatal care. This really results in prevention of stillbirths as well as prevention of early neonatal deaths. deaths and becomes critical in addressing and achieving the Sustainable Development Goals. And then informed decision making, if there is early recognition of illness, both by the family and the healthcare worker, then there's improved access to healthcare. And then there's also prevention of unwanted pregnancies, because we see a lot of women that accidentally fall pregnant, they don't access antenatal care, and the outcomes are really not good. So what we then did is to implement the pregnancy surveillance to better understand. So if we are saying prevention is most if we take care of the pregnant mom, what can we do to sort of understand health-seeking patterns, quality of care, and issues associated to pregnancy? So we implemented a pregnancy surveillance about 3 years ago across the different sites with a main aim of measuring pregnancy outcome, facilitating timely detection of stillbirths and neonates so that we can prevent them, and then looking at factors that affect outcomes. So our pregnancy surveillance is mainly a platform for us to be able to intervene and do something before the child is a stillbirth or a neonatal death. And the value of this is that it gives us a comprehensive database. It increases antenatal care uptake, because when a pregnancy is detected, they're timelessly linked to antenatal care. And ultimately, it gives us that opportunity to strengthen our health systems and make sure that the mother delivers a safe pregnancy. I'll just briefly touch on how we have been translating CHAMP's findings into public health actions. So our starting point is local solutions. The way that the CHAMP's project works is that before we see something in a scientific journal, we need to see it with the local Ministry of Health. We need to see it with the local community. We should have made a change in the community before we think of publications and manuscripts. So the local solutions start at the local level, working together with households and communities. We impact on clinical practices, including post-mortem review. So we encourage across the sites to set up mortality reviews that not only look at CHAMP's data, but also look at other cases outside in other facilities, so that we're able to strengthen the health system and improve quality of care. We also look at what is the best way for diagnosis. So we use the expertise that we have in the countries, not only for the surveillance, but also in epidemic response, detection of any unusual pathogens. And then our analytic capacity is available either through the site office or through our main office in terms of when it's required by our ministries of health or key partners. Just to touch on the impact of CHAMPs and what really accurate cause of death information can drive. So when you know what's causing any unexpected result, or what's causing child deaths or maternal deaths, you're then able to really develop the prevention methods that are needed. So some of our findings, which showed a very high prevalence of CLEB, pneumo, GBS, and RSV, have informed on the development of vaccines. And we are driving to make sure that our sites become one of the first sites to have access to these vaccines. Addressing HIV gaps, I gave an example of how the CHAMPS program is able to really delineate where the gaps are so that we can address them. One interesting finding that has come from CHAMPS, and we're working with the various ministries of health to map out interventions based on this, is the issue that there are multiple causes of mortality. So it's not just addressing one and we reduce. We need to look at what's a combination of packages that can be implemented. We also have high quality data that is really showing us the links between environmental causes, nutritional causes, and causes of death. And a classic example is the link between neurotube defects and folic acid deficiency in Ethiopia. So we are now currently working with the Ministry of Health in Ethiopia to assist them to implement a policy on fortified salt. And then our data is being used broadly outside of just our sites to inform on modeling efforts so that we better understand the burden of child mortality and maternal mortality across our CHAMPS areas and beyond. And the CHAMS infrastructure itself has been very instrumental in supporting public health emergencies. So during the COVID pandemic, for a full year, the CHAMS activities were suspended and the platform was used for COVID response across all the sites that we're working on. In Africa, we are currently monitoring the Mpox situation with that possibility of CHAMS sites also assisting in diagnosis or response as and when needed. And then lastly, I will just touch on what our priority areas for intervention are. So malnutrition is really key, and we have a lot of projects that we are funding that are addressing malnutrition. Just an interesting finding that we are seeing is that if we start nutritional lessons and nutritional adequacy at the household level, you prevent a lot of malnutrition in the community. So we're working with mothers, we're working with community leaders, community influencers to have sessions where we talk about what is nutritious food in the context of our traditions and cultures. So I'll give an example. There's one site where children are not allowed to eat eggs because it interferes with their memory. So that's a cultural practice. Now we go out and we give the benefits of eggs. We try and, really explain that there's nothing wrong with your child eating eggs. You can give them and they're highly nutritious. Another example is when we go to families that are a bit able, some of them view fast foods as a sign of socioeconomic affluence. So you find they give their children fried chicken, fried potatoes, while they're eating traditional food. So we have had to come back to the drawing board and saying, what you're eating, your traditional food is the most nutritious food, and that's what you should be giving children. So we really go down to the grassroots. We work with the communities in which we work with to make sure that the interventions that we implement are contextually relevant and actually implementable and doable. We also have a huge focus on antenatal care and perinatal care, because if we address this, we reduce 80% of our deaths. There's quality of care issues. We have a network-wide working group, and we're really happy to incorporate Pakistan, the partners in Pakistan, into this quality of care working group. The idea is to make sure that we improve our health systems and we have good quality care when our patients come in. Antimicrobial resistance is a big theme that has come through our results, and we're working on understanding the drivers of infection and also working with policymakers to see which treatment regimens really work. And then we have a focus on HIV and malaria as well. A potential new area is us looking at vaccine-preventable diseases. This has come up that even though our EPI programs are widely expanded, there are gaps that we would benefit from working with and addressing. I would really like to acknowledge the CHAMS families and communities, without which this work would not be possible. And we really are grateful that despite their grief, they do take time to talk to our teams during this difficult time and avail their babies to give samples that are really valuable. So a really great thanks to the CHAMS teams as well as the families in which we work in. Thank you.
Thank you, Dr. Mutevedzi, for such insightful details on the decode process and how data can truly drive life-saving actions. Finally, we are delighted to welcome Dr. Shabina Ariff, Associate Professor at Khan University, who chairs the decode panel and will go through findings of decode process and focus on how CHAMP's work translates into actionable data for public health strategies in Pakistan and beyond. Dr. Shabina, the stage is yours.
So thank you everyone. It's a hot day today. Assalamu alaikum also, and good afternoon. I might sound a bit odd because I've got a bad flu, trying to keep away, but that's one of the hazards of working in clinical areas and also in research. And a lot of my colleagues here undergo the same problem. So my job has become a lot easier because a lot has already been talked about. From a lens, a global lens, right? CHAMP's global lens, how is it helping? I'll try to take you through what we are doing in Pakistan and how it has helped us in understanding the causes of death so we can intelligently use our resources which are limited and have big impact. That's the whole idea of CHAMPS. So as clinicians, as researchers, this is what we are trying to do. I think we know now what we are looking at, and I'm really happy to hear that maternal deaths is going to be included, because maternal and newborn cannot be separated. They're one and same, and they're interconnected. If you want to save mothers, we need to save newborns. If we want to save newborns, we want to prevent stillbirth, we must work on the mothers as well. Unfortunately, this has been something which has come up a bit late, but I'm very happy that it is there. And also a disclaimer that I have joined CHAMPS very recently, and it's only this year that I joined in June, but it has been a wonderful experience working with experts and with Dr. Momin, and I think the team, the field team, the Decode panel, and our collaborators deserve a good clap, because this is tough work. Believe me, we all are researchers, but doing MITS is actually tough work, especially the cultural background that we belong to. So a big shout out to the entire team. So basically this is what we do, verbal autopsy. Just a bit about verbal autopsy quickly for people who are not aware of what verbal autopsy is. Verbal autopsy, as the name entails, is basically a method where we try to find out the cause of death by visiting the families who had a deceased, and we give them some time, 2 to 4 weeks time before we approach them, let them get through the grieving period so they're happy to discuss with us. And it is sort of an open narrative where people like to talk about their deaths. You know, mothers, they love, I wouldn't use the word love, but they do want to talk about their newborns who didn't make it. And that is a time where they share, and believe me, they remember. Every mother remembers a loss, a stillbirth loss or a newborn loss. So I think that is one important piece, that narrative. And then there are closed-ended questions which we try to take. The hospital record really helps. But even verbal autopsy and hospital records together do not really give us that confidence. That is this death due to preterm? Is this death due to say birth asphyxia or sepsis? And even seasoned clinicians are unable to sort of, tease out the two causes of death. So herein MITS come in, and I think MITS is a very valuable tool, and which really adds to the evidence, because I consider cause of death is like, you are actually evaluating a murder, and you're looking for clues. You are looking for witnesses, you're looking for clues, and you put them together, and then you sit down and try to find out what actually happened, and you tie the dots, one dot to the other, look for plausibility, and then be confident enough to make a diagnosis, which will then help us in channelizing our investment. With that, I move to the next slide. I'll skip this because you all know. This is also the same slide. So what I just want to say for this slide, every component is important. It's a teamwork, every component. Without any one of these, we probably will not have that much confidence in coming to a diagnosis. So all the components of the MITS are extremely important. So coming to the data, what we have is, these are the three sites. If you look at the box up there, let me see if I can, yeah. So these are the three sites, Ben's Colony, Ibrahim Hedri, and Akbar Goat, where we have these number of death notification. Dr. Momin has entailed in depth what we do. And the consented numbers are 386 who actually consented to be a part of the trial, a part of this entire project. And then 72 MITs were collected. The number here that you see is 314, which actually did consent but did not give MITs. All right, so we still have some information, that is verbal autopsy, and also the medical records. The VA was collected in 65 verbal autopsy, as I told you. And so the thing about verbal autopsy is you have data collection, the data comes in, and you look at the narration, you look at the systemic questions that are asked, respiratory, cardiac, infection, birth history, and all of that. And then a physician actually tries to come to a diagnosis, and this diagnosis is based on ICD coding. Once that diagnosis is made, there are two physicians who look at the evidence and very separately, and then they try to come to a diagnosis. If the diagnosis matches based on the information they have, which is hospital records plus verbal autopsy, they may say that the baby died of birth asphyxia. If you have a condition where two physicians are giving two different versions, one is saying this is birth asphyxia, the other is saying this is prematurity, then a more experienced third physician comes into play who is blinded to the first two diagnoses and then makes a diagnosis. That's how we do verbal autopsy, and there are multiple, if people are interested, there's a lot of literature which is available on verbal autopsy, both from Pakistan and from South Asia and Africa. So then we have the clinical data in 61, and finally the decode panel. We are very happy to say we have done 50 such cases, and I'll try to take you through some of them. So some of the faces are familiar, some of them are sitting with us. Dr. Farah is sitting here, Dr. Furqan is sitting here, Dr. Zishan is here, Dr. Halima is also here. These are all code, and we have Dr. Sana here, Dr. Maria. So most of them are here. So this is a multidisciplinary team. We have histopathologists, we have pathologists, we have ID experts, we have obstetrician, both from Dr. Fareen from AKU, Professor Halima from the public sector. So we are looking from both perspectives. And we have Anita Hutwani and Furqan from the microbiology, pathology. We have social scientists, we have epidemiologists, Shyam Sundar. So it's a very rich combination. And putting all of this expertise together, we try to come to a diagnosis. This is the process. So you have the four sources of evidence, which is the microbiology lab, the histopathology, the tag tracker, the packages of VA with all its clinical records. It gets uploaded into the REDCap and then into the GEMS portal. And then finally, a request is generated. The field people, the doctors, they sit down together and they make a report. And then this report comes in to the weekly meeting that we have for the decode panel, which looks both at under 1 year age deaths and over 1 year death. So findings very quickly. So we've looked at the global data. Let's look what we have from the 50 cases, odd cases. This is a gender distribution, all right? So the blue is male, and the purple should be pink, but purple is female. And you can see the stillbirths, they're more male, deaths, stillbirths, than female. If you look at the first 24 hours, the ratio is same. There are 4 females, 4 male. Early neonatal death, more males. Late neonatal deaths, which is around 1 week to 28 days, similar 3 in each gender. And infant is a 7 in males and 4 in females, and child death, if you look, 1 in male and 5 in females. A bit of, there's this thing about whether the females actually, is there a care seeking similar to male and female? So maybe this slide can give you some ideas about that. Are we still struggling with gender inequity, or are our girls, young girls or young children, female babies are coming to the healthcare provider, and when are they coming to the healthcare provider? So I'll touch that later on, but just to highlight this aspect. This is the stillbirth by age distribution. So stillbirths 24, and we saw in the global data and the multi-country CHAMS data a similar slide. Neonatal 31, we are struggling with under 5 neonatal mortality, and we know that neonatal mortality is contributing significantly. Infant death and child death. So you can see the majority of the pie chart is being occupied by neonatal death and stillbirths. Even if we are able to bring down and cause a dent in these two, that will lead to significant reduction, and we will be able to achieve the SDGs. So now, place of death. Very interesting place of death. If you look here, 65% are hospital deaths. So it's not only access, it's when you reached, how you reached, at what time did you arrive at the health facility, what services did you get. So then comes in the concept of quality care. We know now from evidence that a lot of deaths actually in LMIC are occurring at facility, We know now that it's more institutional deliveries than community deliveries. But then comes in the quality. It's not enough that it is institutional delivery. It's important that these deliveries are conducted with standardized care and that newborns and children receive quality care. So the element of quality care is another finding that is coming through the CHAMPS data. If you look at the hospital versus hospital versus home deaths, what you see is that the blue are stillbirth, the orangish mustard is neonatal, gray is infant, and child deaths are in somewhat orange color. So basically what this slide is trying to tell us that for every age group, you do have a high rate of death in the hospital. Look at the stillbirths, and also for the neonatal deaths. So there is a significant number, and almost 50% of infant death are occurring in the hospital. So again, facility deaths is one important finding, irrespective of the age of death. The graph that you see there is a data that comes from a population-based study, the VASA study, which we looked at verbal autopsy and social autopsy across Pakistan. And this was in 2017 and 18 across Pakistan, and where we saw that the neonatal mortality was somewhere around 40, and the stillbirth was somewhere around 39. So our data is almost similar. So what we are looking here is this, that neonatal mortality is the highest mortality in both VASA and social autopsy, as well as through CHAMPS data that we have. And we believe there is, complication around the perinatal death, as mentioned by Portia, that it is basically around childbirth that things go wrong, and we are unable to pick up high-risk pregnancies, and hence the poor outcome both in the mother and the neonate. Again, I think the same situation for stillbirth and home deaths. These are the areas where we really need to look. Home deaths are around 50%, if you remember, child deaths were at home. So maybe care seeking is late, or maybe they are going, as Portia mentioned, to quacks. In Pakistan, we have a huge problem with quacks, with self-healers, and also self-medication. That is another area I think Dr. Momin can allude later when we collect the data. There's a lot of self-medication that occurs in our population, and people working in public sectors such as Dr. Nasir would know that a lot of patients would first try their best to somehow get treatment through pharmacist, and then when nothing was, then they would end up in a public sector hospital almost dying. So these are very important social, cultural factors that come out through this CHAMP data. Just want to stress on the quality of care, and I think I'm very happy to hear that CHAMPS is actually working across quality of care, because without it, no matter how many facilities we build in, no matter how many hospitals we have, no matter how much HR we have, till we don't have the quality of care that is required for that particular disease, we will not be able to save children. Stillbirth are classically divided into antepartum and intrapartum. Antepartum means that before the onset of labor, and intrapartum means that the mother did go into labor, she felt the labor pains, and then the baby died. So we divide classically into intrapartum and antepartum. Majority of the deaths across globally, and previous data also shows that the proportion of antepartum deaths is high. It's difficult to find the cause of antepartum death. Sometimes it's very sudden. You don't know, is it a maternal cause? Is it a congenital anomaly? Is it a metabolic disorder? Is it a placental pathology? So it's extremely difficult to pick antepartum deaths. However, the intrapartum deaths are the low-hanging fruits, because majority of them are around the type of delivery. And these are the deaths that can be prevented if we know exactly what caused the death. Was it delay? Was it, delay in diagnosis, mismanagement, arrived late, or did not go a C-section when there was obstructed labor? So let me give you an example of a MITS case very quickly. I'll just like to tell you that this was a stillbirth, and this stillbirth, the gestational age was almost 40 weeks, gravida 7. That's another issue, and I think that also data needs to come out. It's not in these slides. The gravida of the mothers. We have been seeing in the panel go Dr. Farah and Furqan, Dr. Furqan, they are here. Dr. Halima is here, gravida 12, gravida 14. What are we looking here? I mean, what is happening to the women? How will she be able to give a birth to a healthy newborn? She's totally malnourished, substance abuse, gravida 12. So this data is also extremely important. In some way, we should project Dr. Momin's suggestion and see what can be done across this area. Family planning is one very, it's a sore subject with Pakistan. But I think that's very important. So coming back to the case, the ultrasound was done. Now see, the data for the ultrasound was so important because it brought in two high risk, one an IUGR and a transverse lie. If we did not have this ultrasound data, it would be very difficult from verbal autopsy to be sure that this was an obstructed labor. So, and then moving on to the culture, in this particular case, unfortunately, culture and TAC was not done. But the MITS, what did it show? It showed the placental pathology, and it showed placental insufficiency. The gross morphology was also different. The placenta was small for the age, gestational age, and hence we know that something happened which was related to the placenta, okay, and that led to the death of the newborn, a stillbirth. Neonatal deaths, these were the causes of death for newborns. We had 10% of our cases died of complications of prematurity, 50% asphyxia, and 40% neonatal. Some are following the global trend. It's almost the same across. So MITS, this is a very interesting case in which there was sepsis and prematurity. And because we had the hyaline membrane disease pathology, histopathology with us, we grew bugs in this particular patient where you can see the Klebsiella pneumoniae and the Pseudomonas. So it became easier for us to put the dots together with this sort of a history. And remember, sepsis is so difficult to diagnose. Every baby who comes into a neonatal unit is called sepsis, presumed sepsis or clinical sepsis. So when you work through these cases, if you get evidence which really points towards and tell you the etiology, you can put these complications, these presentation along with the CSF and blood culture finding and then come to a diagnosis. So we know this patient had sepsis. It was a late onset sepsis because the baby presented at 10 days of age. And the underlying cause could be prematurity because we know premature babies are at risk. Their immune system is not good, and hence this can result in them being more prone to infection. And another factor I think is the HIA, hospital-acquired infection, that we should all be really concerned about now, and the AMR. These are some of the immediate and underlying cause of death, and they follow the global data on pneumonia, on sepsis. Some of them are still undetermined, and just like to pick up one point here, which is failure to thrive. Can you see these 4 cases? So these were severe malnutrition. Some of them look like malabsorption, some were, failure to thrive, that they were not able to put on weight. Some of these babies were born low birth weight, and hence I think malnutrition is one of the most important underlying factor in our population, which predisposes them to a number of illnesses. And then the congenital heart disease, we were able to pick this. If we did not have the MITS, we would not be able to pick congenital malformations and congenital heart disease. And another point that we did discuss during our panel code was introduction of X-rays, radiology, which would really help us. So I think that's something we put forward to Dr. Momin, and he's looking into it, but I thought just that would really add to the armamentarium and make things even more easier for us to come to a final diagnosis. Again, children underlying this, they are same across, but just like to tell you about this baby who had TOF. A typical history of TOF was being seen at a cardiology unit, but somehow succumbed to one of the TET spells and died of hypoxia. And we had the tissue specimen that showed severe hypoxia. So this is a classic example of how MITS has really helped us. It's very difficult. I've done lots of them, more than thousands and thousands of verbal autopsy. I would still be not sure in putting a tetralogy of Feller there if I didn't have the histopathology and Dr. Zishan really helps us in these cases because he brings in the diagnosis that we want, and that really makes us confidence in making these diagnoses. Quickly, so we had this case where we were debating, is this aspiration pneumonia or is it something else? The history showed that the child had failure to thrive, was not gaining weight, had difficulty in breathing, was lethargic, was not digesting, and for the last 2 days, he stopped eating well. This is a child. And when we looked at, and in his presentations would look like myocarditis or dilated cardiomyopathy. Now, even the best of clinicians would say, how can you diagnose it? Give me a tropi, right? Or give me something, give me a big heart or a big liver, and then I'll say this is myocarditis. But look at the histopath. The histopath did it all. The kid did have aspiration because of the final event of his life, but his underlying condition was myocarditis. So this is what CHAMPS does. And I don't think anywhere with verbal autopsy, we would be confident in making this diagnosis. Hence, this goes into another etiology, which probably did not exist in verbal autopsy. So that's how MITS helps us. You can see sepsis is always there across all stillbirths, chorioamnionitis in the mother, neonates, culture. So again, very important. Culture-proven sepsis. I know people who work in the public sector, it's very difficult, for them to hold back antibiotics or not to escalate antibiotics because they don't have an antibiogram. They don't have cultures available with them. So see, in these patients, majority of the patients, we had culture-proven sepsis. So sepsis is another challenge that we face in terms of etiology across all age groups. Respiratory distress syndrome, 8 cases, most of them were premature babies and died because of respiratory distress syndrome, hyaline membrane disease we got in the histopathology, and the findings were suggestive of respiratory illness. So now, were these deaths avertible? That's the question, right? And that's what we are doing here. Yes, majority of the deaths were avertible. One of the components of CHAMPS is we get to be asked, could you have done something different? Could you have saved this baby? Professor Halima gets to be asked, could this not be a stillbirth? And she would say, yes, if 1, 2, 3 happened. And all of those things are no rocket science. They don't require a huge amount of money. They require capacity building, HR, infrastructure, and awareness, advocacy, awareness, standard case management, accountability. That's what's going to change the way, how we work and will help us in, bringing down the under 5 mortality. So most of these cases, we had a consensus across the panel that these are preventable deaths. And they are across all age groups. It's not only neonates and stillbirths. We can save infants, we can save child. We just need to know what is the cause of death and how can we improve the care-seeking behavior and quality of care. And you've seen some of these labels, but these are some of the CHAMPS collaboration. And I would just say I'm a clinician by heart and a clinician researcher. I do both, but the closest thing is neonates to my heart. So when Momin told me that, Shabina, would you be interested? I said, yes, I would be interested because this is so important work and we only get one lifetime. So I believe to make the best of this lifetime when we are young, I actually consider myself young, and try to do the best within us. So thank you so much for your patience and for listening to me. And thank you again for the entire CHAMPS team for giving me an opportunity to present this.
Thank you, Dr. Ariff, for your valuable insights into how data can be effectively turned into action on the ground. We have heard so many enriching perspectives today, and now it's time to open the floor for our panel session. I encourage everyone to take this opportunity to engage with our esteemed speakers, ask questions, and delve deeper into the topics covered. Now, I would like to invite Dr. Ali Faisal Salim, who is an associate professor in the Department of Pediatrics and will moderate the panel. For the panel discussion, we would like to invite our panelists, Dr. Momin Kazi, Dr. Portia Mutevedzi, Ms. Rosie Henson, Dr. Shabina Ariff, Professor Nasser Sadal, Executive Director of National Institute of Child Health, and Professor Halima, Head of Department Gynae Ops, Jena Postgraduate Medical Center.
Bismillahirrahmanirrahim. Thank you very much. It was so exciting to hear so many good things in just a couple of hours, and how excited to hear about that majority of them are actually preventable, which is something which is fascinate each one of the clinicians who is sitting here, and also the team worker who work with the families and others. When I heard about this champ with the Momin, I say how you go into this kiosk, and I realized this is not a kiosk anymore. It's something that you able to do, and you delivered it. Thank you, Momin, for doing it, and for the country, and for also for Pakistan. Thank you. So before I open the forum for the audience, I have just few questions, and I really appreciate if the central team, Dr. Portia and Dr. Rosemarie, right, would like to answer that, right? So the question is that how this data, which is from the developing countries, right, is different from the developed country, particularly when you see this mortality thing and preventable thing. How you think, how you just tell us that, okay, these are the things that is, this is different from developing versus developed.
Thank you for that question. So essentially what is mainly different is the socioeconomic status, and that drives differences in health systems, differences in quality of life. So when we look at the causes of death, developed countries don't have a lot of infectious diseases. Their infant and child mortality is really low. So they average around 7 per 1,000 live births, 10 per 1,000 live births. If you look at Africa, we are in the range of 50 per 1,000 beds, 100 per 1,000 beds. We even have one of our sites that has 180 deaths per 1,000 live beds. So the mortality figures themselves are different. The causes of death are different. We see a lot of infectious diseases in resource-limited settings. In developed settings, we don't see a lot of that. It's more chronic conditions, and their children are able to survive longer after delivery. Birth asphyxia is very typical of African settings, Asian settings, and other low-resource settings compared to the modern world or the developed world. And this is really because their health systems are advanced. So I do concur with what was presented in terms of what's needed for prevention is not rocket science. We already know how to prevent these deaths, and if we just implement these changes in our health systems, you know, to be able to measure the heartbeat of a baby during a delivery, monitor how the mother is progressing during delivery, be able to diagnose high-risk pregnancies and transfer them on time, having good diagnostics. If we look at infectious diseases, we don't have good diagnostics at the point of care for us to definitively say, this is the pathogen that is causing the disease, and this is the treatment that's available. So the causes of death are different, the health systems are different, the treatments are also different. We find that a lot of the first-line drugs that we give are not even, the pathogens are not responsive to them. So if we had good quality drugs as well, potent drugs, then we would be able to resolve some of these issues. But what is really good is that when we look at low to medium income countries, the challenges that we have are very similar. So what you see in your CHAMPS catchments, you are able to translate it and transpose it to other countries where we don't have CHAMPS. Even within Pakistan, what you see in these areas, you're able to translate it into other areas where we don't have CHAMPS. So the benefit can be widely spread, even though, you know, we are working in one specific area. Thank you.
Yeah, so Dr. Rosemarie, why don't you just tell us about when you see this data, there are a lot of deviation in terms of mortality age groups. So we see a very small component of children less 1 to 5 years of age. We can understand that the mortality rate are different in younger compared to the older. Do you think is this the real reason, or there may be something else behind that reason?
I think it's what Portia was talking about. I think that when we take a look at our results and findings across the network, one of the things we have found, you know, we're working in areas that are high mortality, right? So, you know, so we have these findings in Pakistan. They're not a whole lot different than our other sites in Africa. And I think one of the big issues that we're faced with on a regular basis is the type of care that women are getting, children are getting, access to perinatal services. I think we're seeing the same types of issues that again can be addressed. And it's probably not going to take a lot of resources to actually address these problems, but it's going to take a commitment by the political and policy structures within these countries to actually do something to save these children. So these children shouldn't be dying. These infants shouldn't be dying. These babies shouldn't be dying. So that's a big concern. And we have, remember, we now have data since 2016. So we have a lot of data. And we'll continue to have that. I think that we're very, very interested in being in high mortality settings where you have limited data to see what else is happening with those settings and what we can do to help those families and to save those children.
Yeah, so when you see this data as a complete, right, can you tell us that if there are children who are more than 1 to 5 years of age and the consent was not given for doing certain things, so Momin can help us in Pakistan side, but when he knows that majority of people do not give the consent for mates and others, is that the reason for not having those children in the midst, or just because they're not dying, or they're just surviving well?
Maybe Shabina, you can answer, and then I can answer from the field perspective.
Yeah, so a valid question, Ali. See, the proportion of child death and neonatal death is something we know. Our major proportion of under 5 is neonatal mortality. So you will see more neonatal deaths in any population-based data, number one. Number two, child death is also underreported to some extent because these deaths, if you saw, it's a very small data set, but if you saw the data, there were 4 deaths, child death at home, and 4 deaths in the hospital. So there are issues of care seeking, and we know from our experience as clinicians and also as researchers that the care seeking behavior of these children is slightly different because newborn is a vulnerable population who falls sick very easily, very quickly, and doesn't give you much time to save. While children are comparatively resilient to infections like diarrhea, pneumonia, so it takes some time for them to seek care. And as Portia gave an example that, self-care seeking, and in our setup, I mentioned that a lot of care is, you're using antibiotics, antihistamines, and you wait for things to really get worse before reaching the hospital. So I think that is why you're seeing lesser number of children being reported. And yes, I agree, and we can look into the social aspect, whether bigger children, is it difficult for parents to give consent for MITs?
So sorry, I think this is thank you for asking this question. This is very pertinent question in sense when we were designing our surveillance, and I think the reason for Pakistan being the 9th site, our strength is collecting the samples at the community level. And the major reason to do that is to cover not only hospital deaths, to cover unfortunate home deaths as well. And then and for that, that was, for us, that is the only or the best way to cover both home and hospital death. And in doing that, what we saw that as we looked at our year one data, we were able to cover all the strata, including stillbirths as well. As Portia shared some of the data, that some of the sites had their proportionality of stillbirth was very high, and we wanted to make sure that our surveillance strategy covers all the strata. Now, having said that, up till now, there are two age groups which we think which are quite challenging. One is home deaths, at birth or within 1 week. That is a very that we are trying our best to get that population, that mortality population, and that is because of the TBAs. And so and I'm especially talking about the home birth. And if you see national, international data, that is where data is missing, I think, especially from the home birth. The other population, rightly, as you pointed out, is 1 to 5. And 1 to 5, the major reason is, I think, because as the child grows, and we are also looking at, we still have a very small data, but we are still looking at stratification between male and female as well, gender-based as well. And so it seems like as the child becomes older, especially the male baby, it's considered as a young man, unfortunately, who has passed away, and then the trauma level has been very high. So this is, again, we are at very early stage of our study. We are, the qualitative anthropological team is doing case studies as well. But our, what we really want to focus is that from the surveillance point of view, we are able to capture all deaths.
Yeah. So maybe we can open the floor for discussion. Dr. Faiza has a question.
Yeah, sure. Open the floor, and then we can take Dr. Halima.
Yes.
It's okay. I can come in later. No, I'm just saying that it's just the way that our communities actually also value life. So the value of a newborn is not the same as that of an older child, because they have invested more time. And actually, our referral rates for babies when they get sick to a facility are lower as compared to the acceptance rates that we get for older children. So an older sick child, the acceptance for referral, as we do it from these community field sites from the clinics. So I think that is explaining some of this. And of course, we do know that, 65% of our under 5 deaths are all neonatal. So I think this is very consistent with what at least I know for our sites where you are working, right?
So Professor Halima, I think, so maybe people of you, if you really want to ask a question, please raise your hand so I can direct you. But before going to that, so the stillbirth data, which is mentioning here, is like, it's a huge, I would say, as a matter of fact, it is an eye-opener for a majority of I would say, government team members, right? Because what they really talk about is neonatal mortality, infant mortality, but they haven't talked about this stillbirth, right? So when you come across this kind of information to the ministries, what are your expectations, their response, and how are you going to convince them about this data and the way forward in terms of planning, in terms of future for the country?
This is a very sad question, I must say, and I'm really not excited to discuss the response to it, because our government somehow is still waiting for WHO centers to do the MPDSR, what to talk about stillbirths. The maternal deaths, a woman who's been cooking yesterday is dead today, and even to review that death, we are waiting for WHO to bring a project and then discuss. And even various units and wards only sit when WHO sends them letter. It has to be our own responsibility to report those deaths, discuss the causes behind them, and discuss all those social behaviors behind them and come up with some kind of policy change and strategy, what to talk about stillbirths. But okay, yes, evidence does come up, and this is a very strong evidence. And if we can convince by using this evidence, then I'm very bright in thinking that maybe if there are more sensitive people in government, because the Madam Health Minister currently seems very clued up, she herself being a pediatrician and a woman, she seems like that it touches her heart. So maybe whenever there is a possibility, I would like to sit with CHAMP's team and bring in all these stories which can result in averting these stillbirths for these moms. And I would like to add one thing. In a maternal behavior, we talk about having pregnancies spaced at a proper time. But if you care for a woman who has just given birth to either a stillborn baby or whose child has undergone a neonatal death in 24 hours, the type of aggression in that woman is very different. She just wants to ask us when now she can become, despite being undergoing a cesarean birth or a very traumatic instrumental birth, or even managing a PPH when she underwent 3 transfusions, she underwent an ICU, and then she comes back to the ward. The first question she asks is, when can I plan another pregnancy? So if you save babies, then you can have those moms plan the next pregnancy maybe at an interval. So it has, what to talk about spacing the pregnancy when she hasn't got an alive baby. She would like to bring the next baby as soon as possible. So I think keeping that maternal behavior in mind, we must think on this aspect of caring for the pregnancies and the vulnerable babies who can undergo a stillbirth, to be more vigilant to take care of such pregnancies so that they can give to a live child. And then they would not plan that early, I must say.
Yeah. So as an ID physician, the AMR always come into the highlighting, and I was looking into that 9 out of 10 mortality somehow is related to the infection, right? So this AMR thing, that come and surprise you, Portia, in this study, or you were expecting okay, we are going to expect the AMR issue?
So AMR in itself was not really a surprise, but what we found surprising was AMR in our neonates. Because globally, antimicrobial resistance is going up, and we were expecting to even see more of it in our communities where people go to a pharmacy to get antibiotics. We have kiosks that sell antibiotics, and people traditionally think if you don't get an antibiotic, you haven't been treated. So there is high use of antibiotics, low adherence. So we expected AMR, but more in the infant, not in the neonates. So it was a bit surprising to see that even in our early neonates, we're already seeing antimicrobial resistant pathogens. And that's why we're now having a concerted effort to understand issues of colonization, transmission from the mother to the baby, and also environmental investigations in our NICUs. Are they getting it in the hospital? What exactly is happening? We have one particular site where they also noticed that when they tested neonates in the community in the first month of life, they were seeing the same pathogen pattern like we see in the hospitals. So we've implemented a data to action project on that site just to really understand what's the interface between our hospital infections and environmental infections. Are these being driven by older children when they come to visit the hospital, then they go back into the household? Or is it when the child is discharged and then they come back into the hospital? Just for us to understand colonization, transmission patterns. And ultimately, our goal is to inform on the treatment. What we find, unfortunately, is that most of the drugs recommended in our treatment protocols do not work for the pathogens that we are seeing. So we need to first get buy-in from the government, from policymakers, to recognize that we really need drugs that are potent. We need proper diagnostics so that by the time a child is put on an antibiotic, we are sure that, it's a microbial infection. And also the third is for our populations, the communities to understand that we'd rather stay away from antibiotics and only get to them when it's really dire. Yeah, and so we are just further trying to understand that period when the mother is pregnant, during delivery and in the neonatal period, where is the infection happening and where are the reservoirs for these antimicrobial infections? Thank you.
So, Momin, just last few questions before. So you are enrolling the study participants from one part of Karachi, right? And do you think your study results will be generalizable to the entire population? That's one question. And you also just have a question which you just come into my head is, are you come to the exhaustion of your results right now, or you want to do it more?
So thanks, Ali. I think it's a great question. This is something which we are asked again and again, and especially when we are working with the government. I think what we have to look at is the surveillance model. What we looked at, we have to look at, and what Dr. Portia talked about, that it's not the number of cases, but it's what is the cause of death. Because what we have to look at, what we want to look at, that it's not only the cause of death. When we are looking at the cause of death from, for example, at AKU, or when we are looking at the history of the child, or when the child was admitted. So what we are looking at is the holistic picture, which is basically once the case is admitted, or once the death from the information, the holistic information, even after death, the verbal autopsy, the history at the hospital of the child, the history of the mother, if the history is there. So overall, what is the information, and then we are doing more than 160 tests. So that's why it's not only, and then also liaison of that data with your demographic surveillance data as well. So one requirement of CHAMPS was to how do we look at our, we have to have a demographic surveillance data so that we can also look at the demographic data, look at the immunization data, and the maternal data as well. And then for us, that is the reason that we are, I'm grateful to Professor Halim and Professor Nasser, Dr. Farjadu is not here, that we, we take even it's only our catchment area child, but the hospital, unfortunately, where they passed away, we get the information from there as well. And then, of course, as you know, that, it's a semi-urban population, so we are covering all ethnic groups. Now, the next step for us, and this is discussed with both Sindh government and with NIH Islamabad as well, that we, this is Pakistan site, but we need to increase our catchment area. So one thing in discussion is to add our Matiari rural site, because this is going to be a rural site having a DSS, or adding a rural site with a DSS that might give us the complete holistic picture of urban and rural setup.
Thank you for that pertinent question, because it's important for us to really distinguish the need of continuing mortality surveillance versus doing something about the data that we know. So going now into phase 3, which is from the 11th to the 15th year of CHAMPS, the sites will not be doing the same thing. There are certain sites where we feel like they've reached saturation in terms of collecting mortality causes, so they will go into the data to action and intervention mode. There are certain sites where we feel that they're not going to benefit from doing any stillbirths because they have a huge number of stillbirths, so they can either move to another age group or move to pregnancy surveillance or other activities. So going into the next phase, we're really going to look at each site, its specific strengths, look at the data to see if they've reached saturation, is there anything new we'll get out of mortality surveillance, but also work with the ministries of health and key partners to align priorities. So if we're moving away from just causes of death, what are the national priorities, what are the local priorities, and how do we make CHAMPs adapt to those requirements and needs?
I think one of the things that we're going to be doing in phase 3 is that we're going to require the states, we're going to require the sites to go through a reapplication process. Let me be clear, that doesn't include Pakistan, because Pakistan is a new site, and we didn't think it was appropriate to require. Yes, yes. Well, I mean, Pakistan is still in a startup phase. I mean, it's hard. You know, this is a lot of work. It takes, what did it take you, about a year to get up and going? And in some sites, we've seen a couple years. And our sites in Nigeria, it's been really difficult in terms of hiring the staff. You need a multidisciplinary team. You know, it's one thing to have the resources. It's another thing to spend the money, and then it's thirdly building the relationships with the communities and with families. And so one of the things that sites will be doing, which we think is really important, is that through the reapplication process, they're going to have to do a reassessment of their surveillance effort. And then, as Portia is saying, you know, have we reached a saturation point? Or you could see a country come back to CHAMPs and say, you know what, we're going to transition out of this particular catchment, but this is where we want to go. And we think that would be really exciting. We think that would be really exciting. The other area of interest in Africa is Central Africa. And so we're under I would say it's a directive from the Gates Foundation that we explore a place and a site in that part of the world. But don't forget, we also are directed to find co-funding. So if we find co-funding, then we're able to expand the number of sites that we're able to work with. And at some point, Dr. Momin here would come to us and say, you know, I'm interested in working in other parts of Pakistan. And we would be really open, really, and I think it's fantastic that you're thinking about a rural location.
So my questions will not go to end, but let me see if there is a hand raised. Yes, we have a hand raised here. So, yes, please introduce yourself and then ask a question.
Assalamu alaikum. My name is Salma Tariq, डेटा कलेक्टर BSc सेंटर. पहले तो मैं परमिशन लेना चाहूँगी, इतने बड़े फॉर्म पे इतने सीनियर सब बैठे हैं, तो क्या मुझे कुछ कहने की इजाज़त है, कुछ सवाल करने की?
बिल्कुल इजाज़त है, और मैं आपका सवाल अंग्रेज़ी में ट्रांसलेट भी कर दूँगा.
ठीक. बस मेरा सवाल ये है कि आज पूरे सेशन में मैंने देखा कि मतलब डेथ्स और होम डेथ्स कम हैं, हॉस्पिटल में डेथ्स ज़्यादा हैं. और मुझे तकरीबन 2011 से मैं जॉब कर रही हूँ. आपके साथ मैंने स्टार्ट किया था MIPV से, तो पोलियो पे हमने काम किया. डॉक्टर फरा के साथ हमने नमूनिया पे काम किया. और फिर भी पाकिस्तान में पोलियो का हर साल केस आ रहा है, नमूनिया से इतनी डेथ्स हैं. और क्यों है? मतलब हमने इतना काम किया है, क्या हमारा निज़ाम ठीक नहीं है, या हम अपना मैसेज सही कन्वे नहीं कर पा रहे, या हमें अगर डेथ्स हॉस्पिटल में हैं तो या हमें डॉक्टर सही नहीं मिल रहा, इलाज ठीक नहीं है. यहाँ ये सब बैठ के देखना बहुत आसान है, लेकिन जब किसी के घर में ये होता है ना, अभी रिसेंटली मेरी बेटी की डेथ हुई है प्रेगनेंसी के दौरान, बच्चा भी एक्सपायर हुआ है, बेटी भी. तो मैं बहुत तकलीफ़ से गुजरी हूँ ये सब देख के कि मतलब ये सब एक बहुत आसान है. इतनी डेथ्स हो गई, न्यू बॉर्न्स, न्यूनेटल डेथ्स हो गई, मदर डेथ्स हो गई. जिस फैमिली के साथ गुजरता है बहुत तकलीफ़ वाला होता है. तो ये नहीं हुआ कि वो हॉस्पिटल नहीं पहुंची, कोई अच्छा डॉक्टर नहीं था, बहुत अच्छे हॉस्पिटल गई, डॉक्टर्स के पास गई, लेकिन फिर भी कहाँ गलती होती है, हम कहाँ जाएं? ऐसा कोई जो है मतलब क्या है कि सेहत के डॉक्टर सही नहीं मिलते, या फिर हम सही तरह अवेयरनेस नहीं दे पा रहे. देखिए प्रेगनेंसी पे भी हमारे पास सेंटर्स में अब प्रोजेक्ट चल रहे हैं कि वो स्टार्टिंग से लेके डिलीवरी तक वो آبزرویشن میں ہوتے ہیں، اس کے باوجود نیو بورنس کی اتنی ڈیتھس ہیں، مدر کی ڈیتھس ہیں. آج کل میں جو ہے امیونائزیشن پہ کام کر رہی ہوں. ہمارے پاس ایک لسٹ آتی ہے BCG کے بچے جب ہم چیک کرنے جاتے ہیں تو آدھی لسٹ میں بچوں کی ڈیتھ ہے، مدر کی ڈیتھ ہے. تو بہت تکلیف ہوتی ہے کہ اتنا کام کرنے کے باوجود جو ہے نا ہمارے ساتھ ایسا ہو رہا ہے ہمارے علاقوں میں. شاید یہ نہیں ہونا چاہیے اتنے اس کے باوجود. تو اب سوال آپ خود سمجھ رہے مجھے.
So she's Salma and she's our data collector and she is with us for last 13 years, right? Work on certain projects. And her question is very valid and actually very heartfelt as well, because she work in polio, she work in immunization, she work in maternal immunization, she work with a lot of other projects. But what she sees is that the positions remains the same. There is no improvement in mortality, there is no improvement in mom dying, there is no improvement in polio, nothing is working, right? So her question is like, what is lacking and why it is lacking and what we can do to improve these circumstances. So I would like to say, Dr. Shabina wanted...
First, if you allow me to, so I want to give, as a panel, we want to give condolence to her. So میں اردو میں پہلے جواب دے دیتا ہوں پھر وہ ہے. تو سب سے دیکھیں، سب سے تو ہماری طرف سے آپ پورے پینل اور ہماری پوری ٹیم کی طرف سے ہم بہت افسوس ہے اور آپ کے ساتھ ہم اس میں شامل ہیں. اور سب یہی وجہ ہے یہ پروجیکٹ کرنے کی، یہی وجہ ہے. مطلب یقین جانیں یہ ٹیم بیٹھی ہے، بڑا مشکل ہے کہ ہم وہاں اس سے سیمپل لیتے ہیں، مگر بہت سی مائیں، بہت سے بچے، اسی لیے مائیں اور نانی اب ہمیں جیسے جیسے ہمیں پروجیکٹ کا پتہ چل رہا ہے وہ خود ہمیں فون کرتے ہیں. اور اس پروجیکٹ کی اصل وجہ ہی یہ ہے کہ ہم لوگوں نے ابھی تک جو ہے کہ کیا وجہ ہے کہ اس کا ماؤں کا، خاص طور پہ بچوں کا، اور انشاءاللہ اب ہم پریگننٹ وومن سرویلنس بھی شروع کریں گے کہ ماؤں کا، بچوں کا اور ماؤں کا اموات کی وجہ یہ کیا ہے. تو اس پروجیکٹ کی اصل یہی وجہ ہے. ٹھیک ہے. سو آئی تھنک آئی کین موو.
میں بھی آپ کے ساتھ افسوس کے ساتھ یہ بات کہنا چاہوں گی کہ ہم یہ چیزیں اکثر دیکھتے ہیں، بیکاز آئی ورک ان اے سیٹ اپ جہاں پہ جو سب سے فینومینل اسٹڈی ہے پاکستان کی، شاید موسٹ سائٹڈ، مدرز براڈ ڈیڈ. اٹ واز ڈن ان آور یونٹ بائی پروفیسر رضیہ قریجو اینڈ پروفیسر صادقہ جعفری ود زیرو فنڈنگ. دا موسٹ سائٹڈ اسٹڈی آف پاکستان شاید ابھی تک. تو ہم ایسے ہی ایک سیٹ اپ میں کام کرتے ہیں جہاں پہ بس خواتین آتی ہیں اور وہ اتنی ینگ لڑکیاں ہوتی ہیں جو مری ہوئی ہوتی ہیں. لیکن میں اس جگہ پر 24 سال سے کام کر رہی ہوں. میں یہ آپ سے ضرور کہوں گی کہ نمبرز میں کمی آئی ہے. میں یہ نہیں کہہ سکتی یہ وہی ہیں جو پہلے تھے، لیکن جو کمی آنی چاہیے تھی اس لیول کی کمی نہیں آئی. اس کے ساتھ شاید ہسپتالوں کی کوشش تو بڑھ گئی ہے، جو ہسپتال کے لیول پہ کوشش ہے وہ شاید امپروو ہو گئی ہے، لیکن ہمارا جو سوشل سٹیٹا ہے، جو ہماری پبلک ہے، وہ بہت تیزی سے غربت کی طرف جا رہی ہے. صرف غربت سے مراد ایسی غربت نہیں ہے کہ اللہ نہ کرے بالکل کھانے پینے کو ترس رہے ہیں. ایسے گھرانے جہاں مناسب سمجھ بوجھ ہے، اتنا کھانا پک جاتا ہے، وہاں پر بھی چیزوں کو پرائرٹائز کرنے کے لیے اب وقت نہیں مل رہا ہے. جیسے کوئی خاتون پہلے 4 بار وزٹ کر پاتی تھیں، وہ شاید اب 1 بار آ پاتی ہیں. ہم ان سے جب داخلے کا کہہ دیتے ہیں تو انہیں کچھ اور کام یاد آ رہا ہوتا ہے کہ اگر وہ آج چھوڑ دیں گی تو وہ نہیں ہو پائے گا، اس نے وہ بچوں کی ٹیوشن کرنی ہے یا وغیرہ. ایسے بہت سارے سوشل فیکٹرز ہیں. لیکن دیکھیے، جب میں وہ ڈیٹا بچپن سے بنا رہی ہوں ڈاکٹر رضیہ کے وقتوں سے، کہ پہلے جو ڈیتھس تھیں ویسی ڈیتھس نہیں ہیں، یہ تو میں آپ سے کہوں گی. اور اب جو ڈیتھس ہسپتال میں ہو رہی ہیں یہ وہ ڈیتھس ہیں جو پہلے سڑکوں پہ ہو جاتی تھی یا گھروں میں ہو جاتی تھی. اب وہ مریض ہسپتال پہنچ رہا ہے. اب سڑک پہ اور گھر میں مرنے والی عورتیں ختم ہو گئی ہیں. پہلے ہمیں پتہ ہی نہیں ہوتا تھا. I just wanted to tell her that we didn't know previously that how many mothers die in the community or on the roads to the hospital. But now most of them die in the hospital. So these are the ones who were previously dying on the roads to the hospital. And those who reach in critical condition, many, more than 50% of them get saved now. And the community deaths are now very less. It's everyone who's just very critical is brought to the hospital and then they die. بہت کم ہے کہ گھر ہی میں مر گئی، ایسا بہت کم ہے. وہ کسی نہ کسی ہسپتال میں پہنچ رہی ہیں. لیکن میں نے عرض کیا کہ واقعی ابھی اس پر زیادہ تیزی سے یہ نمبر کیسے کم آئے، اس کے لیے ہم بہت سارے دماغوں کی طرف، بہت سارے درباروں کی طرف دیکھ رہے ہیں، جس میں آغا خان بھی ایک دربار ہے، بیکاز میری ریسرچ کیپیسٹی نہیں ہے، میں یہ سب کیسے کروں. تو جو کر رہے ہیں ہم ان کے ساتھ ہاتھ بڑھا لیتے ہیں کہ چلیے آپ کیجئے، ہم آپ کے ساتھ اپنا دماغ ڈال دیں گے، اینڈ لیٹ سی ہاؤ کین وی ورک ٹوگیدر ٹو ریڈیوس دس. ٹھیک ہے. اور میں اگر اس میں کہیں پر بھی آپ کے ساتھ بیٹھ سکوں، ہم لیٹر آن اس پہ بیٹھتے ہیں، تاکہ شاید میرا کوئی ایسا لفظ ہو جس سے آپ کو ڈھارس ہو جائے. ٹھیک ہے. ڈاکٹر ناصر، آپ کچھ کہنا چاہیں گے اس سلسلے میں؟
بسم اللہ الرحمن الرحیم. بسم اللہ الرحمن الرحیم. آپ نے بالکل صحیح فرمایا. جیسے کہ کویشچن ہے کہ نو ڈاؤٹ ایکچولی میرے خیال میں ہمارا بھی اسٹڈی کے اندر انوالو ہونے کی ریزن یہی ہے کہ وانٹ ٹو نو کہ واقعی یہ اس طرح کی جو ڈیتھس ہو رہی ہیں اس کا بیسک کاز یا روٹس کیا ہیں. تو اسی لیے میں بھی اسٹڈی میں انوالو ہوا ہوں اور اپنی ٹیم کو لے کے، تاکہ ان چیزوں کے بارے میں پتہ چلے، تاکہ ہم آگے اس کو امپلیمنٹ کر کے پریونشن کی طرف جا سکیں. اور یہی ہم کر سکتے ہیں کہ وی ٹرائی اینڈ ٹرائی، اور اپنی ہوپس کو چھوڑنا نہیں چاہیے اور اس کو ہمیں کنٹینیو رکھنا چاہیے. دیٹس مائی I just informed that that is the reason why I involved in the study, to know why these deaths are occurring. Because she's right, she's a very a victimized person who is right that her daughter has died in that accident. And anyhow, when they reach in the hospital, but did not know, it was not anybody can't save her. So we are in there to know why these deaths are occurring, and we can prevent after this decode all of this activity. We can see the literature, see the things and the results, and then we have to apply on that things and make policies to improve that things.
This evidence is huge, very valid evidence. Let's use it.
So سب سے پہلے تو بہت دکھ ہوا، اور واقعی زبانی نہیں، یہ کسی کی بھی، اور آپ خود ینگ ہیں اور آپ کی بچی ان کا، تو ہم سب کی طرف سے دلی جو ہے افسوس ہم سب کی طرف سے جو بھی یہاں بیٹھے ہوئے. دوسرا یہ یونیورسٹیز اور ایکیڈیمیا کا ایک رول ہوتا ہے، اور وہ رول ہوتا ہے ٹو گیدر ایویڈنس اینڈ گائیڈ. ٹھیک ہے. تو ہم جتنے لوگ یہاں بیٹھے ہوئے ہیں، ہم کوشش کرتے ہیں کہ ایسا ایویڈنس دیں گورنمنٹ کو تاکہ وہ چینلائز کرے اپنے ریسورسز اس کی امپرومنٹ میں. اور میں اگری کرتی ہوں ڈاکٹر حلیمہ سے کہ کیونکہ اب کافی عرصہ ہو گیا سسٹم پہ کام کرتے ہوئے، تو ڈیفینیٹلی امپرومنٹ آئی ہے، لیکن وہ لیول آف امپرومنٹ نہیں آئی ہے. اور دوسری جو امپورٹنٹ چیز ہے وہ پرائیویٹ سیکٹر کا رول ہے، وہ جو ہے نا وہ تھوڑا سا ہم سے پیچھے رہ گیا ہے. پرائیویٹ سیکٹر سے مراد بڑے ہاسپٹل لائک آغا خان نہیں، آپ کو بھی پتہ ہے بہت سارے چھوٹے چھوٹے ہاسپٹلس پورے کراچی شہر میں، لاہور میں، جہاں کوئی ریگولیشن نہیں ہے، کسی کو پتہ نہیں ہے کیا ہو رہا ہے، کوئی قسم کی اکاؤنٹیبلٹی نہیں ہے. ٹھیک ہے. تو یہ وہ ایریاز ہیں جن پہ ہمیں ضرور دیکھنا بھی چاہیے، اس پہ بھی کام کرنا چاہیے، اور کوشش کرنی چاہیے. جیسے ڈاکٹر ناصر نے کہا تھا کہ ہوپ سے انسان، ایک ہوپ ہی ہوتی ہے انسان کے پاس جو اس کو روزانہ اٹھاتی ہے، صبح کام پہ لے جاتی ہے. اگر اس دن ایک اچھا کام ہو جائے اور گھر واپس لوٹے سکون سے، تو نیند اچھی ہوتی ہے. تو یہ ہوپ مت اپنی لوز کریے گا. ٹھیک ہے. اور ہم چاہیں گے کلوجر ہو، تو آئی ایم اویلیبل. Dr. Halima is available, or we will provide you if you need. Dr. Momin can talk about it. We have grievance support for grieving also. وہ بھی ہم اس پروجیکٹ کے تھرو کرتے ہیں. اور مجھے اس لیے پروجیکٹ پسند ہے کہ ہم صرف کام نہیں لے رہے ہیں کمیونٹی سے، ہم ان ریٹرن میں بہت ایمپتھی دے رہے ہیں، ہیلپ کر رہے ہیں. تو آئی تھنک یہ سکسیس ہے اس پروجیکٹ کی، اور ہم امید کرتے ہیں کہ جیسے آپ کے ساتھ وہاں کسی اور کے ساتھ نہ ہو، اور ہماری کوشش ہوتی ہے اور کوشش ہمیں رکھنی چاہیے. تھینک یو.
سو تھینک یو ویری مچ. میں صرف ایک میسیج یہ دینا چاہتا ہوں کہ جتنے بھی ہماری ٹیم ہے، بیکاز آپ کو پتہ ہے ریسرچ کی بہت سارا اسٹاف ہے جو کہ ایک پیشنٹ کے گھر پہ جاتا ہے، فیملی کے گھر پہ جاتا ہے. آپ کی بہت رسپیکٹ ہے، اور جتنی بھی یہ اسٹڈیز جو کہ پچھلے 20 سال سے 2 دہائیوں سے چل رہی ہیں، بغیر آپ کی کنٹریبیوشن کے، بغیر آپ کے ہمارے ساتھ چلنے سے یہ پاسبل نہیں تھی. سو اگر میں آپ سے کہوں نا کہ ہماری جو کی ٹیم ہے اس میں آپ سب کے سب بالکل شامل ہیں. جہاں پہ ڈاکٹر مومن ہیں، جہاں پہ ڈاکٹر فرح ہیں، ڈاکٹر فائز ہیں، ڈاکٹر عمران ہیں، میں ہوں، لیکن ہم سب کے ساتھ ساتھ آپ اس ٹیم کا حصہ ہیں जो कि सारे के सारे चीज़ों को लेके चले। तो हमें बहुत फ़ख्र है आप पे, और बगैर आपके हम कोई भी काम नहीं कर सकते। बहुत बहुत शुक्रिया आपका। So I would like to end this discussion with special thanks to our leadership from the central office, Ms. Portia, Ms. Rosemarie, Dr. Momin Kazi, Dr. Shabina, Dr. Nasir, and Dr. Professor Halima. I give a mic to Ms. Maria again. Thank you.
Thank you, Dr. Ariff.
Thank you to all our panelists for this wonderful discussion. As we wrap up today's session, I would like to express my gratitude to all of our speakers for their invaluable contributions and to all of you for attending. The CHAMPS program's work is critical in shaping healthier futures for children across the globe, and it's clear that data-driven, evidence-based strategies are key to reducing child mortality rates. Now I'd like to invite Dr. Faiza Jahan, the chairperson of Department of Pediatrics and Child Health, Khan University, and Dr. Momin Kazi to please come on stage and present souvenirs to our esteemed guests. I would like to invite Dr. Portia to please come on stage and receive her souvenir. Now I would like to invite Ms. Rosemarie to please come on stage and receive her souvenir. I would like to request Dr. Nasir Sadal to please come on stage and receive his souvenir. I would like to invite Dr. Halima to please come on stage and receive her souvenir. I would like to invite Dr. Portia to please come on stage and present souvenir to Dr. Faiza Jahan. Now I would like to invite Dr. Imran to please come on stage and receive his souvenir. Okay. Dr. Portia, please come on stage and present. Miss Rosemarie, can you please join us on stage and present souvenirs to our Decode panelists? Dr. Portia, you need to, can you please stay? Yeah.
Have you noticed how he always has us working?
I would like to invite Dr. Shabina Ariff to please come on stage and receive her souvenir. I would like to request Dr. Ali Faisal to please come on stage. I would like to request Dr. Portia and Ms. Rosemarie to please present the souvenir to our PI and Thank you again, and I hope today's discussions inspire ongoing collaboration and innovation in your own work. Have a great evening, everyone. Tea is served outside. Can
So I think I'll just take the opportunity to thank my team. They really worked hard. Again, I am the front man, and especially the people. Kareem is standing there. So Kareem and our Saima, Nazia, Rahil, Maria. So and Faraz and the team standing in the back as well. Thank you so much.